you very much, Mr. Chairman, and thank you very much for the kind introduction. It's very over-exaggerated. I'm not an expert in many of these things. These are areas that I'm very keen on, and here today to talk to you about optimizing beta-lactam therapy. Just so I can benchmark my talk, any microbiologists in the room? How many intensive care doctors in the room? Any nurses? Any pharmacists? Any PK/PD experts? John, put your hand up. Okay, so we're going to talk to you about beta-lactam. I'm a very practical person, so I'm going to hopefully give you some practical advice about how I do things in Oxford, what the literature shows, and hopefully make you reflect a bit on what you do on your intensive care unit. But I'll open up with this. Hands up, those who know what this is. It's very pretty, isn't it? Any ideas? This is the super strain of gonorrhea that has gone to the UK, and it's a public healthcare warning in all hospitals in the UK because we're running out of antibiotics to treat it. This was imported from this part of the world, actually, unfortunately. It is a big problem. Whenever you go into any antibiotic talk, antibiotic resistance is a problem. These are data presenting from the WHO. Don't worry about taking pictures for the slides. I will give you all the slides on the website later on, which you can access for free. I'll also give you the references in the website so you can click on it. You don't have to look it up yourself. But antibiotic resistance is a problem. Why? Because we use it very, very frequently, very, very readily. And perhaps the other side of the issue is that new antibiotics are very, very slow in coming out into the market. Unlike cancer therapy drugs or new anticoagulants, etc., antibiotics doesn't make money for the companies. So there has been a void of new antibiotics in the market, and actually we're going to hear a little bit about using old antibiotics following on my talk later on by my friend and colleague, Dr. Yan. You need to know your bugs. In order to give the right antibiotics, you need to know your bugs. This is, again, a slide from a colleague and friend. This is European data. Unfortunately, I couldn't find any data for the local area, but as you can see, within Europe, there is considerable variation in what bugs cause what disease, okay? There are some resistant bugs within that list. Some areas are very prone to having very resistant organisms. You need to know and work with your microbiology colleagues. The guiding principle in all of this is the right drug for the right patient, at the right time, for the right duration. That seems obvious, and we'll try and touch on all these elements during the course of my talk. This is what a beta-lactam looks like. It's called a beta-lactam because of this structure, the beta-lactam ring. And actually, the family of beta-lactam is quite extensive. It includes the penicillins, the cephalosporins, the carbapenems, the monobactams, and the carbapenems. They've got multiple generations of it. This is the family of beta-lactam. 90% of my antibiotic use in my unit fall into that category. What's yours? How do beta-lactams work? They all work by inhibiting cell wall synthesis. They bind to something called the penicillin binding proteins. This is gram-negative, gram-positive, and they block the development of the cell wall. In the concept of bacteriostatic and bactericidal, you already know, but the resistant organisms, the way they work is by reducing access to the PBP, the penicillin binding proteins. You can stop them from getting to it, you can stop them from binding to it, or you can destroy the antibiotics with beta-lactamase, and that's why there is one of the major worries we have is the extended spectrum beta-lactamase. It's important to know the kill characteristic because that helps us work out how we dose our antibiotics and what interval we use it as. Some antibiotics are concentration dependent, i.e. you need to get it really high above the minimum inhibitory concentration, and that's your aminoglycosides. Some antibiotics work by how long you stay above the MIC, which is the beta-lactam. So this is this principle that I'm going to focus on. Now, if you think about how you dose your antibiotics, you can do it via intermittent boluses, i.e. bang, 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 3 times a day, 4 times a day, once a day. You can do it as a continuous infusion, which is that line there. Or you can do extended boluses, somewhere in between the two, this green line here. And again, depending on the antibiotics, that's how you affect your MIC. So what does international guidelines tell you? You're all, I'm sure, very familiar with the Surviving Sepsis campaign. It tells you to give the right antibiotic at the right time to the right patient, etc. But there is a minor point there, which is 0.5 in the antibiotic session. And they recommend dosing strategies of antimicrobials be optimized based on accepted PK/PD principles and specific drug properties in patients with sepsis or septic shock. But notice the strength of that recommendation. BPS, best practice statement. It makes sense. But the evidence there, and I'll show you, doesn't necessarily allow for any stronger recommendation. So let's think about where we work, the intensive care unit. It's a dangerous place to work. It's a challenging place to work. I enjoy it. I have a very good team of colleagues who are with me. I work very closely with a microbiology who does daily ward rounds with us. Are we very good at what we do? I like to think so, but the data would suggest otherwise. 30 to 60% of antibiotics prescribed in ICU are unnecessary, inappropriate, and suboptimal. That's 1/3, so 1 in every 3 patients we get it wrong, or more than half of the time. That's a considerable number. So the challenges of working on an ICU with regard to antibiotic use is, we want to give antibiotic early. Our patients are sick. We may only have one chance to get this right. So we want to get it early, we want to be effective. But also, our patients are also quite sick. So the ability to deliver, say, oral antibiotics in someone who's had gut surgery may not be feasible. We also have an increased chance of meeting resistant organisms. And perhaps more importantly, in terms of dosing, the PK/PD relationship in our patients change fairly frequently during the course of their intensive care stay. And let's talk about that bit. So I've already shown you this side. We're interested in the betalactam, so how long can we get the concentration of the antibiotics above the MIC? That's what we're interested in the minimum when it comes to betalactams. So let's show by a show of hands first. How many of you have got microbiology ward rounds on a daily basis? 3 times a week? Okay. Not daily, not 3 times a week. Once a week? How many of you do not have microbiology ward rounds? Okay. How many of you, with regard to beta-lactam therapy now, run a intermittent bolus? Oh my gosh, this is not what I expected. How many of you run a continuous infusion? Over 24 hours? How many of you do sort of an in-between, an extended infusion? Okay. This is quite a spread, I think, of practice. How many of you monitor your drug concentration, so TDM? 1. Okay. Okay. So this is a survey, international survey, of 9 intensive care units. The next speaker is on this list. Jeffrey Littman, who's also in this talk, is on this list as well. So they surveyed 9 intensive care units. These are the sort of drugs that therapeutic drug monitorings do, that are measured. Take-home message from me is the fact that even in those units that they do monitor the drug concentration, the advice given or what they do, the management strategies with that, is so variable. So no one actually knows what they're doing or is consistent in what they do, and hence, you might as well flip a coin, really. I touched upon it already, so I'm going to give you a bit more detail. So pharmacokinetics in the critically ill. When the patient first comes to the intensive care unit, their PK/PD dynamics is one thing. As they get better, it changes. As you add in renal replacement therapy, the PK/PD relationship changes. As you take out half their gut because of an ischemic bowel, or your surgeons take out half their gut because of ischemic bowel, there are PK/PD changes. So if you remember your pharmacokinetics principles, absorption, distribution, metabolism, excretion, all of this are affected and changes during the course of that patient's critical illness. So how many of you would take into account all of these things when you dose your antibiotics? Hands up. So how many of you prescribe 4.5 grams of tazocin TDS? There you go. It changes. I'm somewhat surprised sometimes when I've got very good pharmacy colleagues that help me make that decision along with my microbiology colleagues. I'm sometimes surprised that given the extent of changes or possible changes, I don't change my antibiotic dosing as regularly as I think I could. Again, another slide that summarizes the PK changes during the course of critical unwellness and how it can affect your dosing and how you give your antibiotics. Again, I'll give you all these slides later on. So let's go into the nut and bolts of it. So, betalactams. It's a continuous, perennial discussion. Continuous or intermittent. So in this room, by the show of hands earlier, most of you are leaning towards the continuous side of things versus the intermittent side of things. In my unit, we're about to make that transition from intermittent, which is what we've always done, to continuous. But what does the data tell us? The data tells us that whether you go for, the data tells us that continuous infusions inevitably improve your PK profile. That's what it shows you. If you run a continuous infusion, you spend more of your antibiotic concentration time above the MIC. That's what it tells us. It also tells us in some of the studies that your clinical cure rate is better. What it doesn't tell you is, it doesn't improve mortality. Our patients still die, whether you give them intermittent or continuous, except for one trial. And the trial was based in Malaysia, okay? It's called the BLISS trial. That is the only trial I'm aware of that showed a mortality benefit. So this is the meta-analysis. This is yet another meta-analysis. And this is yet another trial, which all say the same thing. If you run a continuous infusion, in terms of your PK/PD relationship, which I showed you earlier, it is superior to intermittent. But it does not translate to a mortality benefit. Fortunately, it also doesn't translate to increased resistance, so on and so forth. I think this is probably the most recent of the meta-analysis, and this was published by just this year, February 2018, by colleagues. Things in the pipeline. This is Bling-3, betalactam infusion study. This is led by Jeffrey Littman, who is a speaker in this Congress. So what's it going to do? It's a multi-center trial, 7,000 patients, 70 ICU worldwide. That's mainly Australia, New Zealand, Europe, UK. Again, it will look at continuous versus intermittent infusions. Their primary outcome, trying to address the question I've already raised, is does it affect mortality? So they're going for 90-day mortality as their primary outcome. They obviously look at clinical cure rates and then break down the ICU mortality, the 90-day mortality into ICU mortality, hospital mortality, lower down outcomes or tertiary outcomes. They're also going to look at health economics and resistance. Reflect on what you do on your intensive care unit. Like I said, I'm quite a simple person. This is the data from my hospital, and what the question was that when I prescribed an antibiotics on an electronic prescription system, which we have in Oxford, how long from the time that prescription is made to the time the antibiotics are given? As you can see, antibiotics is quite a time-critical drug. We weren't very good at it. So we would like to think that within half an hour of me prescribing or my registrars or my fellows prescribing antibiotics, the antibiotic is given. That's not the case, and it's quite a shocking reminder. But it also highlights a very important core principle, which is start from the basics. What's happening on your unit? Have you got this data? How many of you look at this in your own unit as part of a audit quality control process? Time of antibiotic prescription to time of administration. Anyone? 1? 2? Okay. Something to think about, I think. So let's talk about antibiotic-based microbiotics, microbiological stewardship. You need a team around you. You need to work together with your antibiotics leads, champions. Your microbiology team are excellent. It does require strong leadership and cultural change. So we went through an extensive process of negotiation, deliberation, when we decided to move from intermittent to continuous. We also planned what data we are going to collect during this change period. Obviously, it's an opportunity to review what best practice is and see if that's applicable and what changes you can make to your own practice in your intensive care unit for your patients. Things change. This is why you need to be aware of what your local bugs are. Has resistance changed? What's the most common pathogen? Have that changed? You might need to tailor your antibiotics, first line, second line, third line, accordingly. The benefits of good antimicrobial stewardship I've summarized for you there. They seem obvious. So to summarize then, I started off this lecture by saying it's all about getting the right drug to the right patient at the right time for the right duration. So, for the right drug, you need to know the right dose and local knowledge. How are you going to give it? Continuous versus intermittent. The evidence currently suggests continuous is superior for the PK side of things, PK-PD relationship side of things. It does not translate to a mortality benefit. Which is it? If you're going to run a continuous infusions, don't forget you are going to need some practical aspects need to be considered, i.e. you need a intravenous line. If you switch to continuous infusion, does that mean you need to put in more line and therefore need to expose the patients to a higher risk of line infections? I don't know. It's one of the things that we talked about when we made that decision. Stewardship is important. You cannot give antibiotics willy-nilly. We are running out of antibiotics. I think the guiding principle of the Surviving Sepsis campaign, giving antibiotics early, is probably a good one, but it also emphasized the last bit, which is de-escalation. Stop when the patient gets better, or at least think about stopping. Shorter courses have been shown in some cases, such as community-acquired pneumonias, to be as good as longer duration antibiotics, so bear that in mind. I will give all these slides and the references for that I've mentioned this thing on the blog. That's the web address there. And I'd like just to highlight to you one of the other resources provided by the European Society, which is the Managing Pneumonia in the ICU course. I've had the privilege of being on this course, and I think there is, after walking out from this course, there is nothing you need to know about antimicrobials in pneumonia. And you've got the program director, course director here to ask questions if you so wish. Thank you.